Good morning. Good morning. Welcome to the Department of Medicine Ground Rounds. Before we introduce the speaker, I want to congratulate all of those who participated in Research Louisville. As you know, every year the Health Science Centers comes together to celebrate and to learn about the research that students and junior faculty and others are performing at the university, and this was held all through last week. And if you look at our website, you'll see all the winners of this year for a number of awards. David Hagen, Austin King, Maria Rosa Velasquez, John Sao, Corey Kircham, Benjamin Touts, Cable Liu, Walter Watson, Gray Stadnick, Emily Guernsey, and our own Jennifer Cook, who actually won third place for the Ruth Rimberg Award for Excellence in Medical Research. Congratulations to all. We always talk about a couple of personalities in history so that we're reminded that we're here because of the efforts and sacrifices of many others. Christian Nusslein Volthard was born this week back in 1942. She was a German developmental geneticist who did a lot of work and published in Nature how different mutations were important for segmentation of the fruit fly embryo. And for that, she won with others the Nobel Prize in 1995 for physiology or medicine. Austin Flint from the Murmur, not the movie. The Murmur, discovered and described by him in 1862, was born on this week in 1812. He was an authority in cardiovascular and pulmonary disorders. But today is about rheumatology. It's about immunology. It's all that kind of stuff. So I want to remind you about Sir Benjamin Collins Brodie. And he died on this day back in 1862. He was a British physiologist and surgeon, one of the top surgeons of the 19th century in London. His name was applied to certain diseases of bones and joints. He pioneered the surgery of varicose veins. He was very into saving limbs. In those days, you had a little something in your leg and they cut it off. So he worked very hard on conservative measures in the treatment of diseases of the joints. In 1843, the tuberculous abscess was called Brodie's abscess. And of course, if you see patients who have locked knees and pain and they're hysterical, that's called Brodie's knee, in honor of Dr. Benjamin Collins Brodie. And Jean Dawson was born this week in 1916. He was a French hematologist and immunologist who described that we develop antibodies against blood when we get blood transfusions, and he hypothesized that genetic variations between people was going to determine how intense was that reaction or not. And so today I leave you with Neil Roberts, the Chief of Rheumatology. He's going to introduce our special guest who's likely to present a terrific presentation this morning.
We have a joint effort of neurology and medicine to bring Dr. Alan Pestronk from WashU. Dr. Pestronk is the sort of national resource on classification of inflammatory myopathies, and the closest thing we have to Armed Forces Institute of Pathology, which disappeared in some defunding in the 90s, I think. There's a website which allows you to see his brain kind of plastered over the internet to figure out a myopathy, and that's the sort of the arbiter that you can reach regarding obscure aspects of classification and the simpler ones as well. He's been professor at WashU for a while, neurology, pathology, and immunology, and head of the neuromuscular section there. He has 230 papers, 230 visiting professorships, including most recently Yale and Dartmouth. He has a long CV, in other words. Begins in Cambridge, Mass, where he was born. Nothing happened for a long time. Then Princeton, then Hopkins, and then WashU. And 2015, he was the Distinguished Clinician of the Year at WashU. So we're going to hear about classification and how that affects diagnosis and treatment of inflammatory myopathies.
Thanks for having me. Greetings from a little bit of west of here on Interstate 64. What I wanted to do today was to tell you how I have a good time on Saturday morning when we read our muscle biopsies. Before I start, these are my conflicts of interest. The Myositis Association pays for me to talk, but I don't take their money except for expenses, and none of this, the rest of this stuff is relevant to this talk today. What I'm going to do is a sort of a couple-part talk. In the first part of the talk, I'm going to talk about pathologic classification of immune and inflammatory myopathies. And in the second part of the talk, I'm going to give you a case. I was told to put a case first, but the case will be in the middle, and show you how we use this kind of analysis to find new diseases and new disease syndromes. If you're a resident, this is all you have to know. It's wrong, but this is what's in the literature about classifying immune and inflammatory myopathies. Bohan and Peter in 1975 distinguished polymyositis as being an inflammatory myopathy, and dermatomyositis if you had a skin rash on top of it. In the 80s and 90s, a new entity, which probably isn't immune, called inclusion body myositis, was added to the classification. And in the last couple of years, it's become increasingly recognized that you can have immune myopathies that have no inflammation. And so people added a separate category called necrotic myopathy, where that you have dead muscle fibers with no staining on this NADH stain here, which have been called necrotic myopathies, and actually are not very specific. So it's my hypothesis that this kind of standard classification, none of these groups are either specific or sensitive in distinguishing the various immune and inflammatory myopathy syndromes, or, especially important, their appropriate treatments. And what I'm going to tell you instead is that muscle is not hamburger. What it is it's composed of three main tissues, and you can see it through the microscope, and the immune system recognizes this as well. This is a cross-section of a frozen section of muscle, and what you can see here is that muscle has actually three different tissues in it. It has connective tissue. There are two kinds of connective tissue. There's the perimysial connective tissue that divides the muscle fascicles, and then there's endomysial connective tissue between muscle fibers. Normally there isn't that much, but it's definitely there. A second set of structures in muscle is vessels. There are two sets of vessels as well. There are intermediate-sized arteries and veins in muscle. And then there are these little guys here that look like a dot that are actually the endomysial capillaries. And muscle is richly endowed with capillaries so that every muscle fiber has an adjacent capillary. And finally, there actually are muscle fibers in muscle. And what I'm going to tell you in the rest of my time is that pathologically, if one recognizes this kinds of structure, one can differentiate different types of immune myopathies that allow me in a dark room on Saturday morning to tell the clinician what the disease likely is, how to manage the patient, and what treatments are likely to work. And in particular, there are two sets of diseases in connective tissue. There are diseases that seem to affect the perimysial connective tissue, and I call those IMPP for immune myopathies with perimysial pathology. There are another set of disorders, and again, I'll define each of these anatomically and pathologically as we go along, of immune myopathies with damage to endomysial connective tissue, and I call those IMEP. There are another set of muscle diseases where the immune response seems to damage blood flow and damage vessels, and these are called myovasculopathies. There are two sets of disorders that involve muscle fibers. There are what other people call necrotic myopathies, and I call polymyopathies, in the fact that they have myopathy with necrosis and no inflammation. There's what other people call inclusion body myositis that I call IM-VAMP, which is a much better name because it includes all the pathologic features. And that's a myopathy with vacuoles, aggregates, and mitochondrial pathology. And then last, there's a set of immune or inflammatory myopathies that are defined by the type of inflammation. There are no or few lymphocytes, but instead the immune features are mainly histiocytic foci. So in the first part of my talk, what I'm going to do is I'm going to show you what I see through the microscope, and then what that predicts about what's clinically going to be wrong with the patient and how the clinician ought to act and treat the patient. First, we'll talk about immune myopathies with perimysial pathology. And there are two kinds of damage to the perimysial connective tissue. Again, here's a normal area of perimysial connective tissue with no vessel stained with VVG, and you can see nice, normal, relatively homogeneous structure. In contrast, in immune myopathies with perimysial pathology, what you see is perimysium with connective tissue somewhat widened, and the structure of the connective tissue is abnormal, and it's fragmented and has these Swiss cheese holes in it. And it also has abnormal large cells, which I'll show you a picture of, again, illustrated better in a second, but these are all histiocytes. There's very little lymphocytic inflammation, but presumably these are some of the cells that are associated with the damage to the perimysial connective tissue. If we're not sure about these cells, we can look for structural damage in another way. There's a histochemical stain called alkaline phosphatase, which normally doesn't stain anything much in muscle, but in disorders of immune myopathy with perimysial pathology, the alkaline phosphatase diffusely stains the perimysial connective tissue, and this at low power tells us right away that we're dealing with a disorder of connective tissue. I mentioned the immune cells in perimysial connective tissue and IMPP syndromes. We identify those with lysosomal markers such as acid phosphatase stain. And here what you can see, again, and this is an area of perimysial connective tissue with all these cells stained for acid phosphatase. Another stain, which is a beautiful stain for these cells and gives us a clue about what they really are, is the esterase, which stains the cytoplasm of these cells. And what you can see here are not only the cytoplasm of the body of these cells, but these amazing processes that stick out into the perimysial connective tissue, and we can sort of think that they're secreting matrix metalloproteases or something else that's actually digesting and damaging the connective tissue. Again, this is a relatively non-inflammatory disorder, although there are histiocytes here. There are relatively few macrophages. The muscle disease in this disorder is not a random muscle disease. The muscle disease tends to be at the edge of fascicles right next to the areas where the perimysium is damaged. And the type of damage that one sees in muscle fibers is necrosis and regeneration. And these are normally stained fibers. And right at the edge of the fascicle, you can see these cells with basophilic cytoplasm and large nuclei, which are regenerating muscle fibers. And up here, you can see a necrotic muscle fiber. And again, they tend to occur in streaks right next to the areas where the perimysial connective tissue is damaged. And again, this sort of gives us a clue about what the pathogenesis of this disease may be. There's some kind of immune response against connective tissue, although we don't know exactly what the antigen is. So what does that kind of pathology predict that the clinician is going to see? Well, what IMPP syndromes pathologically tend to correlate with clinically are multi-system disorders. Particularly 4 systems are involved. Patients have muscle disease where the patient develops moderate to moderately severe proximal symmetric weakness. These patients develop a skin rash. You could call this dermatomyositis, but it's not really, because the skin rash is a bit different. Instead of being the purplish rash, these people tend to have what are called mechanic's hands and have scaly, flaky skin, although it can be in exactly the same distribution over the extensive surfaces of the joints. These patients also have interstitial lung disease, and when I first encountered these disorders, I said, what's similar about muscle and lung? Well, both have a lot of connective tissue in them, so it makes a lot of at least heuristic sense that these patients have both muscle and could have both muscle and lung disease since they have connective tissue damage. And finally, these patients develop a joint disease, which tends to be a seronegative polyarthritis. The epidemiology of these diseases are that this can comprise some childhood, what people call childhood dermatomyositis, so that by no means most of it, and the age extent can also go through to late adult. Like a lot of autoimmune diseases, females are more involved with males. The IMPP pathology predicts that you're more likely to see a particular kind of myositis-specific antibodies in the blood. With this kind of IMPP pathology, 40% of IMPP has associated antibodies, and the most common example is tRNA synthetases, and the most common example of antibodies against tRNA synthetases is histidyl tRNA synthetase or JO1. These disorders also are reflected in the blood in terms of damage markers that reflect disease activity. The antibodies don't. Serum CK can be normal to very high, and these diseases are a particular reason why we measure aldolase. A good population of IMPP patients can have a normal CK, but the aldolase is selectively high. And if you see somebody who's weak and they have a high aldolase, that goes in the other direction and predicts they're likely to have the IMPP pathology. This kind of pathology also predicts that you're going to be dealing with a treatable syndrome, although one that's somewhat difficult to manage. It predicts that corticosteroids are going to be useful as primary immunomodulating agents. It may control the myositis, but one lesson right away is that even if you say, eureka, the corticosteroids have controlled the myositis and the patient has gotten stronger, one needs to be vigilant because the other features of these syndromes may occur independently even when patients are on successful corticosteroid treatment for the myopathy. And thus, other medications over the long term are really commonly necessary, either with the primary immunomodulation or because these syndromes tend to require large doses of steroids for which sparing agents are attractive. Finally, again, even if the patient doesn't have any evidence of lung disease on clinical exam or testing, one needs to consistently monitor at least yearly for the development of this interstitial lung disease, because it's this system that produces the increased mortality, not the muscle disease, which produces mainly morbidity. Okay, so that's IMPP. Now let's talk about immune myopathies with endomysial pathology. And we define this syndrome, these syndromes pathologically by a humoral immune factor, which is we look for deposition of C5b9 complement or membrane attack complex in muscle. Normally, you don't see any C5b9 deposition in muscle. But in IMEP, what you see is deposition of C5b9 on the endomysial connective tissue all through in diffuse areas of the endomysial connective tissue. And so this is a nice pictorial marker of why we call this endomysial pathology, because there's C5b9 deposited on the endomysium. An example of this syndrome is a very interesting disorder called brachiocervical inflammatory myopathy, named in particular because it doesn't produce the diffuse proximal weakness in the first syndrome, but patients get brachiocervical weakness and get head ptosis and prominent weakness of the proximal arms. This syndrome, in addition to having the humoral immune response, also has a cellular response, and it's probably the best example of what in the old-fashioned classification you might call polymyositis. The inflammatory cells surround the perimysial intermediate-sized blood vessels, but the distinctive feature of this disease is there are just not any immune lymphocytes, but this is one of the two inflammatory and immune myopathies that contains B cells, and if you stain these collections of cells for CD20, you see these large collections of B cells. So I abbreviate this syndrome BCIM for brachiocervical inflammatory myopathy, but you could just as well call this B-cell inflammatory myopathy. What does this pathology predict? To neuromuscular people, again, it predicts a syndrome that has a distinctive pattern of weakness with proximal arms weak greater than equal to the weakness in other extremity regions. Again, I showed you the picture. These patients have a high frequency of posterior neck weakness and come in with head ptosis. The degree of weakness is moderate to severe. These patients tend to progress over a period of months. The most interesting feature of this syndrome to rheumatologists is that Occam's razor doesn't work. Virtually every one of these patients has a second autoimmune disease. And the second autoimmune disease can be myasthenia gravis, rheumatoid arthritis, mixed connective tissue disease, or Sjogren's syndrome. And so, again, what we tell the clinician here is, oh, the patient has weakness and inflammatory myopathy, but if there are any unexplained symptoms or signs, you need to be aware that these patients have very often some other immune disorder. Epidemiology here, these patients tend to be adults from 22 to 85 years, females equal to males. About 15% of patients with actual inflammatory myopathies have this syndrome. These patients often have a high CK, but again, going along with the fact that this isn't just a muscle disease, this is the subgroup of one of the two subgroups of immune myopathies where the anti-nuclear antibody is very high and commonly present. So ANA is positive in 92% of BCIM patients, and it's greater than 1 to 640 in 50% of these patients. Finally, this is a treatable disorder. This is the most treatable of all the immune myopathies. You give these patients an adequate dose of corticosteroids and then go to every other day or intermittent steroids of one sort or another, and these patients get better and stay better, and all the brachiocervical inflammatory myopathy patients that I've seen get better. I stop just a second just to say that all the therapies I'm talking about so far are anecdotal in Alan's experience, and there aren't controlled trials of even prednisone in any of these disorders. So again, I'm telling you my experience rather than any controlled trials because there aren't any. Okay, the next set of disorders are called myovasculopathies, and these are immune disorders of vessels in muscle. There are two sorts of vessels in muscle. There are intermediate-sized vessels that exist in the perimysium. They're most nicely stained with a stain called VVG that shows the beautiful fibrillar structure of vessels near the lumen and other structure of connective tissue outside of that. Veins, on the other hand, have a much less organized, wavy fibrillar structure in their walls, and it's a beautiful, direct way of telling arteries from veins. In all these diseases, what you see is that in some way or other the vessel walls are damaged, and I'll show you some pictures of that. Endomysial vessels are capillaries. We stain those with a stain called ULEX, which stains the endothelium, normally all capillaries have endothelium, and so you can count the number of capillaries and see whether every muscle fiber has a neighboring capillary. Again, muscle fiber damage in these syndromes isn't random. The pathology tends to be in border zones of vascular supply, and I'll show you a picture of that in a second. So I got my history for Dr. Roman here, and this is the first case of dermatomyositis in which muscle pathology was obtained. Batten is known for a completely different set of central nervous system diseases, but he also described the first dermatomyositis pathology in the British Journal of Childhood Diseases in 1912. I won't show you his picture in this lecture, but again, the first example of myovasculopathies is childhood dermatomyositis, or what I call through the microscope dermatomyositis with vascular pathology. Again, I showed you one of these pictures a little while ago, but just to give you a muscle anatomy lesson, it turns out that there are two kinds of perimysium in muscle. There's perimysium between fascicles with no vessels, and then there's vascular perimysium that contains arteries, veins, and probably lymphatics in other areas of muscle. These areas are aligned so that they're sort of, if you cut the muscle just right, they're kind of parallel to each other. This is a stain for PECAM, which is also the same thing as, it stains the same structures as ULEX, which is the endothelium, and you can see these yellow areas here, which is the vascular perimysium. And again, here's the avascular perimysium with no larger vessels in it. If you look at a patient with dermatomyositis with vascular pathology, and again, get lucky and section the muscle just right, here's vascular perimysium, here's vascular perimysium, and here's avascular perimysium. And what you see is, as is classic in dermatomyositis with vascular pathology, there's atrophy of muscle fibers at the edge of fascicles, but it's not just a random edge of the fascicles, it's the area of the fascicles between the two vessels in what looks like a border zone. And so I think what's going on in this disease is a chronic partial hypoxia of these muscles that causes them to atrophy. If one looks at the pathology of this syndrome, the muscle fiber and other pathology and vascular pathology is completely different from other disorders. So here's my control VVG stain, artery, vein, but here's the artery and vein pair in a patient with DMVP, and what you can see is the wall looks damaged, and by some mechanism or other, the fibrillar structure is gone, and this is even without inflammation. The vessel wall is damaged in some way, and this is the characteristic feature of DMVP, where there's vascular pathology of both arteries and veins, although there also is inflammation around some of these vessels. This is a lymphocytic inflammation that you can see on H&E stain, but this is the second and last disease where you see B cell inflammation. It's very common that B cells occupy some of these inflammatory, or part of some of these inflammatory infiltrates. Again, the inflammation is perivascular, perimysial vessels, intermediate sized. But the interesting thing that makes a lot of sense in terms of where the muscle fiber pathology is, inflammation is damaging the vessels, but the muscle fiber pathology and atrophy isn't next to the vessels. It's in border zones far away. What happens also in the border zones, presumably because of ischemia, is that if you stain with ULEX, it looks like the capillaries disappear. So here's a low-power ULEX stain. Every muscle fiber has a capillary next to it. But here in the areas of perifascicular atrophy in the border zone, it looks like the capillaries are gone. They're not actually gone. They've just lost their endothelium. And if you stain for a C5b9 complement, what you see is C5b9 complement is deposited on the capillaries that looked like they were gone on the previous section. We think, again, we don't think that the capillaries are damaged because of an immune response, but they're damaged in the same areas where the muscle fibers are damaged, and so we think that damage is related to the chronic partial hypoxia. The muscle fibers themselves, again, this slide superficially looks a lot like the IMPP pathology I showed you before. There are small muscle fibers at the edge of fascicles, but in fact, if one looks at the subtleties of this pathology, what one sees is that there is no necrosis here. This is all a funny kind of atrophy. So here are normal muscle fibers, and here are small muscle fibers, but there's no necrosis or regeneration. If you look at higher power, you see vacuolar changes in these muscle fibers. And what we do to make sure that we're seeing the right pathology is three sets of stains. The first is that these odd atrophic muscle fibers have activated autophagy, or autophagy. And so what one sees is collections of an autophagy marker, LC3, inside these muscle fibers. A second presumed consequence of the chronic partial hypoxia is a mitochondrial disorder in these muscle fibers. So here, this is a normal cytochrome oxidase stain, type 1 and type 2 muscle fibers are stained. But in the area of perifascicular atrophy, these patients lose their cytochrome oxidase activity. And this is, again, pathologically, we're always looking for specific markers. This regional loss of mitochondrial staining of muscle fibers is what's specific for these disorders. Finally, muscle fibers, even in the earliest stages of this disorder in perimysial, near at the edge of fascicles, even when they're not atrophic, they tend to upregulate MHC class 1. And we do MHC class 1 staining routinely in any patient who's suspected to have an immune myopathy, because this can be positive even when all the muscle morphology is normal. You can see perifascicular upregulation of MHC class 1. And then again, really helps us to know that there's a disease there. What does this kind of pathology correlate with? This correlates with an immune myopathy that starts in early childhood, is about 80% of childhood dermatomyositis, but is also 40% of adult dermatomyositis. These patients get weakness that's proximal greater than distal and symmetric. These patients also have a systemic disease. They get the classic dermatomyositis heliotrope rash. Once one understands what the pathology is in muscle, it makes a lot of sense that if you don't treat these patients, they get visceral ischemia and probably have vascular problems in their GI tract as well. And a non-intuitive feature of this syndrome is that this is a subgroup of immune myopathies with an increased frequency of calcification. This also predicts that certain newly identified autoantibodies may be present in these patients. The particular autoantibodies that are worth knowing are NXP2, which predicts dermatomyositis with an increased frequency of calcinosis, and TRIM33 and 24, which predict an increased frequency of neoplasms in adults. This pathology also predicts a treatable immune myopathy syndrome, typically with a response to corticosteroids. The next class in these patients, in immune inflammatory myopathies, patients are immune polymyopathies, and I've left off the itis because these patients have no inflammation. They just have muscle fiber necrosis. An unusual but very important subgroup in these myopathies is myopathy with signal recognition particle antibodies. These patients have a pattern of muscle fiber necrosis under the microscope, which is ongoing. There are necrotic fibers, there are regenerating fibers, but what you can see here is that the pattern of necrosis and regeneration is very different from IMPP. They're scattered, random fibers in different stages of necrosis and regeneration. An amazing feature of this disease, this is really early, but 6 months later, this is what the muscle looks like. There's markedly and rapidly increased endomysial connective tissue, and there's almost no inflammation, either histiocytic or lymphocytic. And so that what this slide implies in terms of disease management, we'll get to in a minute, but you have to treat these patients early and recognize this disease. What the antibody to signal recognition particle is actually doing, nobody really knows. Signal recognition particle is an intracellular antigen that's composed of several protein subunits. It transfers the secretory proteins from the ribosomal apparatus into the secretory pathway. This is the most severe of all immune myopathies. These patients have proximal and symmetric weakness. This is virtually the only immune myopathy that very early in the disease course, one gets 0 out of 5 strength in some proximal muscles. It's really rapidly progressive over a few months. Myalgias are common. Weight loss is common. So people think that this is a paraneoplastic syndrome, but it's not. There's no increase in neoplasm in this syndrome. This is the immune myopathy in which the CK is the highest, often over 3,000. And antibody testing shows that patients have antibodies against signal recognition particle, which is actually a defining feature of this syndrome. Again, this is acid phosphatase showing you the scattered necrotic muscle fibers. If you don't treat these patients, again, endomysial connective tissue rapidly accumulates, and these patients never get entirely back to normal, even when the disease is under good control. Because of all this, presumably because of all this proliferated endomysial connective tissue. All these patients initially show some response to steroids, but virtually none of these patients have a sustained response to steroids. And I was just in a meeting in Amsterdam last week where there was general agreement, although there's no controlled trial, that the optimal second drug in this syndrome is rituximab. And if you treat these patients with rituximab intermittently over a year or two, one can bring these patients under relatively good control and minimize the dose of corticosteroids. If one does optimal treatment in this disease, the prognosis is for slow improvement. If you only use corticosteroids, you'll almost always have relapses, even at high doses of corticosteroids. If you start at 100 a day of prednisone, say, by the time you get down to 50 a day, patients will relapse. And because of all this connective tissue, there's often residual proximal weakness. The last disease that I'm going to spend any time on today is a contrast to the other diseases because it's an inflammatory myopathy that's not treatable. And I call this group of syndromes inflammatory myopathy with vacuoles, aggregates, and mitochondrial pathology, or IMVAMP for short. Other people call some of these disorders inclusion body myositis, but the problem with this term is only half the patients with this syndrome have inclusion bodies. Vacuoles with granular basophilic debris, aggregates that stain for a whole bunch of interesting proteins that are also associated, the same proteins are aggregated in central nervous system disease, and mitochondrial pathology because these patients develop scattered abnormalities in mitochondrial DNA and muscle fibers then can't manufacture cytochrome oxidase. This syndrome has a very distinctive pattern of lymphocytic inflammation that it's distinctive in two ways. First of all, instead of being in the perimysium, inflammation here is lymphocytes in the endomysium, and the sort of sinuous collections of lymphocytes. And the first distinctive feature is that these collections of cells contain both CD4 and CD8 cells, but not B cells or CD20 cells, as in some of the other syndromes. Again, their location is endomysial greater than perivascular. And these cells are doing an amazing thing to damage the muscle fibers, which you can sort of see here. But here's a higher power of that. Instead of necrosis, what these cells are doing is they're in the endomysium and they start focally invading a muscle fiber and they eat away at the muscle fiber, even though the muscle fiber itself is still alive. I sometimes want to listen with a stethoscope and see if we can hear the fiber screaming or something, but in any case, eventually they completely phagocytize the muscle fiber and it disappears. And that's the characteristic and different pattern of muscle fiber pathology in this disorder. What the vacuoles, aggregates, and mitochondrial pathology and that inflammation predicts is a completely different clinical pattern than the other immune and inflammatory myopathies. These patients develop focal asymmetric weakness in the legs. It's leg extension weakness, but particularly you identify these patients when they first walk into the office because they shake your hand like this. They can't flex their wrist or fingers, and that's probably the most useful physical sign in these patients. As the disease goes on, other skeletal muscles are involved, and these patients get dysphagia. The regression is slower than other disorders. This is primarily a muscle disease, and so most of you guys end up sending these patients to us because you can't treat them, and there isn't a treatment. And so we manage the weakness in the patients. In any case, this is a disease of older patients. Females are equal to males. Laboratory-wise, these patients can have a normal or only mildly high CK. Even though this is a non-treatable disease, there are two antibodies that are worth knowing about. The ANA is positive in 25% of cases, but there's a newly identified antibody marker that has that's relatively sensitive. 75% of patients with IMVAMP have these antibodies, but it's not entirely specific. This antibody was identified by Steve Greenberg at Harvard and an Italian group. It's present in 70-75% of patients, and it provides some prognostic implications as well as diagnostic implications. It's more common in females with the disease. It's more common in patients with more disabling features. It's more common in patients who also have respiratory involvement and dysphagia and vulvar involvement and facial weakness. So we commonly look for this antibody both for a little bit of more reassurance about what the diagnosis is, and also it tells us a little bit maybe about what the prognosis is going to be. If one sees all these features, these patients have no response to corticosteroids, no response to most types of immunomodulation. Some of these patients have a short-term, year or two improvement in strength with methotrexate, but then that goes away over time. The last category of disease I'm just going to mention in one slide are the histiocytic focal inflammatory myopathies, where one has collections of histiocytes in muscle. And examples of those are granulomatous myopathies and a set of myopathies that probably don't have a lot of clinical implications, that are called immune myopathies with abundant macrophages. And we'll talk about those in 5 years. So that's the end of the first part of my talk. The second part is going to be relatively short, but again, if one can categorize immune myopathies pathologically, connective tissue, vessels, muscle fibers, and with patterns of inflammation. And so what I'm now going to do is present the case and show you how this patient allowed us to identify a new subcategory of immune myopathy. A 79-year-old white female had 1 month of a skin rash on the arms and trunk, weakness in proximal symmetric involving the arms and legs, dysphagia, impaired swallowing and chewing, and muscle discomfort. Examination showed proximal symmetric weakness in the arms and legs and a nondescript skin rash. But this patient on laboratory testing had a very high CK of 4,000. On muscle biopsy, this patient had a very peculiar thing, which is that I showed you before different patterns of muscle fiber necrosis. This patient had yet a different pattern of muscle fiber necrosis, where all the muscle fibers in one area were necrotic. It wasn't scattered at all. It was focal, just areas in muscle had all muscle fibers were necrotic, and they're all in the same stage of necrosis, where the muscle fiber cytoplasm has pale staining and the nuclear staining is gone. And the way we prove necrosis is by staining for C5b9 complement, and early necrosis in muscle fibers is associated with deposition of C5b9 complement in the cytoplasm of muscle fibers. So again, this was a syndrome that might have been called necrotic myopathy, and you could say, oh, look, the immune system is damaging the muscle fibers. But actually the solution to this, what was going on here, was not any kind of high-power molecular analysis, but instead to take the microscope and turn it to low power. And what we saw was that this is a border zone disease again. So this is collagen 4 staining the basal lamina of muscle fibers and vessels. And what you can see is that there's a border zone distribution of the clusters of these of a clustering of these muscle fibers, and this is presumably even more ischemia than the DMVP, childhood dermatomyositis, and you see actual necrosis of muscle fibers. And again, the other feature here is that this doesn't respect it isn't perifascicular, it doesn't respect the perimysial borders. What it respects is that it's between vascular territories or vascular zones. This is a stain that we use to look at muscle damage. Tumor pathologists use this as a marker of ischemia, carbonic anhydrase 9 or CA9. And again, this is a serial section of the last muscle section. The vascular areas are here, and all between this area, the two vascular areas, one sees not only damage to muscle fibers, but damage to perimysial connective tissue. And if we look at high power, there's also damage to capillaries. So it's perfectly consistent with the idea that this is an ischemic disorder involving all the different tissues and not just muscle fibers. If one looks at the vessels, this is a disorder that tends to involve veins more than arteries. Again, here's our control vessel stained with VVG. And what sees here is the artery has normal fibrillar structure, but the veins tend to have this edematous-like appearance with increased thickness inside the normal lacy structure that surrounds veins. And this is a consistent feature of these cases. And we were struck enough by this case and by one or two other cases to go back and look. at a series of these patients. We concluded that these patients had a myovasculopathy and that their veins had damaged walls, and their muscle fiber pathology was necrosis, but it wasn't just any necrosis. It was clustered in vascular border zones, and again, there was no inflammation. So we went back and collected 8 of these patients. We found that this was a disease of older patients ranging from 41 to 92 years, somewhat more too small to really know for sure, but females were more commonly involved than males. And these patients had a number of features in common. They had muscle biopsies, so that's a sampling issue, but they all had weakness. The pattern of weakness was moderately severe, proximal symmetric. They all had dysphagia. They all had a subacute onset over a period of months that had been relatively rapidly progressive from normal. All these patients had muscle pain. Most of these patients had a very high CK of 1600 or higher. You could call these patients dermatomyositis, but that's not a precise term, as must be obvious by now. 83% did have a rash on the face, trunk, and arms, but the bottom line and the kicker in this syndrome is these patients have cancer. 72% of the 8 patients we saw had cancer. They were the older patients between 63 and 92 years, and these aren't trivial neoplasms. They're hard to find neoplasms in solid organs, so you had to look for them. The treatment in this pathologic syndrome is that the myopathy tended to respond fairly well to corticosteroids, at least partially or completely in different patients. But the main message here, when you see that kind of border zone necrosis through the microscope, is go back and find the tumor, because it's highly likely to be there, especially if the patient is over 60. Again, the prognosis is that the myopathy shows improvement with corticosteroids. The neoplasm is often a solid in solid organs, and its prognosis is poor. We classify this syndrome as a myovasculopathy, and the research into this syndrome is going to have to find vascular, not muscle fiber, target autoantigens. Again, the problem with all immune myopathies is, even the ones with antibodies, is we really don't know what the target autoantigen is. So again, in summary, one can subdivide myopathies on the basis of a lot of different things, but you can't use the classic subdivision. I've shown you today, if you say, oh, you have necrotic myopathies, you're actually dealing with at least 4 different syndromes. Perimysial pathology syndromes have necrosis, brachiocervical inflammatory myopathies have necrosis, regional ischemic myopathies have necrosis, and signal recognition particles. So necrotic myopathy is not a useful term. Similarly, dermatomyositis is not a good word, and if you say you think somebody has dermatomyositis, your next thought is which one? Because again, what I've shown you today is there are at least 4 and probably 5 different syndromes that are immune dermatomyopathies. There's dermatomyositis with vascular pathology, which starts in childhood and has calcifications and B-cell inflammation. There's regional ischemic immune myopathy, which is the paraneoplastic syndrome. It has no inflammation. There's IMPP, which has lung disease associated with it, but has the skin diseases, mechanics hands. And then there are 2 other relatively newly described subgroups. There's malignancy associated dermatomyopathies where the pathology isn't well defined, but they're associated with P155 and TRIM33 antibodies. And finally, David Fiorentino and Stanford and others have identified a somewhat amyopathic, although it probably should be paucimyopathic, syndrome that's associated with another antibody, but again is a dermatomyopathy syndrome associated with MDA5 antibodies. So these last 2 slides illustrate that the old words dermatomyositis and necrotic myopathy really have no precise meaning, and you need to take another step with each of these and say which one. So finally, your friendly muscle pathologist can help you figure out which disease you are dealing with. Connective tissue, vessels, muscle fibers can help you define the syndrome and then define the treatment. And again, with a good muscle pathologist, you get to this point, which is the end of the rainbow. I took this picture out of my hotel room in a beach in Australia, the end of the rainbow, and the end of the rainbow in diagnosis and treatment of immune myopathies is getting the right treatment and then helping the patients get better and not using inappropriate treatments that aren't needed. If I've gone too fast, the highlight of my career is that if you type in neuromuscular, my website comes in above Wikipedia on Google. And so I'll stop there and say thank you. If you have any questions, I'm happy to answer them.
Thank you. Thank you for that, for the course on the definition or classification, pathological classification of myopathies. What makes the muscle the target?
So
what's in muscle that makes it the target?
So what probably the best way of answering that question is a little bit like the debate last night, answering a different question. The issue is, I was listening in my car driving here. I may have gone off the road a couple times. The point is that nobody knows what causes most immune disorders. There's one group of neuromuscular autoimmune disorders where the cause is fairly well identified, and that's the acute immune neuropathies, Guillain-Barré-like disorders. And there, what you can see is that the infecting organism has glycolipids on its surface that have exactly the same structure as glycolipids on nerves. And if you're infected with one type of organism, you cross-react against motor axons. If you do another, you get Miller-Fisher syndrome. And so there's nice evidence that there's cross-reactivity. In these diseases, I think that there are two things going on. First, you have a genetic predisposition to what autoimmune disease you're going to get. And so if you look, every one of my pathologic classifications, the diseases in that category has a different HLA association. So you're probably biologically, again, we can look at you and see what your HLA type is and see which immune myopathy you're likely to get if you're going to get any of them. And the second is probably whatever the environmental stimulus is that triggers the immune response.
Questions, comments? Let's start over there, then we'll come here.
So you mentioned there are like myopathic antibodies that said that between 40 to 70%. Are they exactly?
So the question is whether the myositis-specific antibodies are pathogenic, and the answer is not clearly. A good principle about whether an antibody is going to be clearly pathogenic or not is whether it reacts against a surface antigen. If it reacts against a surface antigen on muscle or other or nerve, it's highly likely to be able to develop experimental evidence that the antibody is going to be pathogenic. In contrast to that, the antibodies against an intracellular antigen, you can bet that there's been a lot of grant money spent trying to passively transfer the disease or showing in some other way that the antibodies are pathogenic, but nobody's been very successful. There's a little bit of evidence that SRP antibodies are pathogenic. Oliver Benveniste in France has been able to show that you can produce some muscle fiber damage with those antibodies. But in general, it's very disappointing. You get a beautiful antibody like Jo1, and it's a nice disease marker, but what it has to do with the disease pathogenesis, I don't know.
So what basically you're saying is that if animal model affect the myopathic antibodies, you get another animal, the pathology may or may not cause.
I'd say it usually doesn't. Right. I mean, in contrast, again, to myasthenia gravis, where you have an anti-acetylcholine receptor antibody against a surface antigen, and then it usually does produce disease.
One more thing, you mentioned use of rituximab when you're and rituximab is used in myositis that is known
So you can use rituximab in anybody you want to try it in. The bottom line of your question was a waste of $8 million. Chet Otis did a huge study where they asked whether rituximab was useful in general in inflammatory myopathies, and they mixed all the diseases together, and the bottom line was it didn't come close to meeting their primary outcome measure. So again, I really think that when rituximab is extraordinarily useful in specific autoimmune diseases. Rituximab is useful when the autoantibodies are IgG subclass 4, for instance. If you find, and that's, if your ears should twitch and say, rituximab is going to be useful in myasthenia gravis, where the autoantibody is IgG subclass 4. It's useful whether used in a different way when you have autoantibodies that have IgM type. You have to give longer rituximab. It seems to work there. And we don't know what the subclass of SRP antibodies is, but it's everybody's experience who's seen SRP patients that nothing works until you give rituximab, and then all of a sudden the patient tends to start to do better, and you can taper the steroids, and you have a patient who's stable over a long period of time. So again, I like to know exactly which disease I'm treating, and then I say, well, maybe rituximab is good. Maybe, like in BCIM, all I need to do is steroids, and I can find a cheap and easy treatment and lower the steroids so there are no side effects.
Dr. Dwight?
It was really interesting the fact that you showed that NHP1 was associated with these very border zones, and then you had what looked like dendritic cells based on the dendrite pattern.
Correct. So those cells that have the great arms are probably cells that have been living in muscle capillaries, and some of them may have come in from hematogenously. But anytime you see a little bit of muscle damage, the cells that have been living in capillaries that were pathologically called pericytes and are labeled by the antibody platelet-derived growth factor receptor beta, migrate out of the capillaries, and you see them in the endomysial connective tissue and the perimysial connective tissue. So in fact, we see those cells fairly frequently in endomysium, and when you have IMPP, you see them in perimysium. And what they're secreting or what the cytokine profile is or how they're producing the damage isn't clear.
Dr. Roberts?
Branch to the rituximab question. So in the immune myopathy with signal recognition
Particle.
you don't get a good hint from lymphocytes in the tissue that it's going to be rituximab susceptible.
Correct.
The antibodies you use. Does that have to do with stage at which the biopsy is taken, or?
No, there ain't no lymphocytes there. Any stage of disease. Again, I have my own theory, which again I think is right, but in 5 years I'll tell you exactly what the immune system is reacting against in these diseases, in SRP myopathy. But it's just this accidental confluence of a number of neuromuscular people who see these people. We all know that rituximab works, and it's not logical. There aren't any B cells there. There isn't an IgM antibody, but nothing works until you get to rituximab. And so again, we were all sitting around at this meeting in a hotel room in Amsterdam, and everybody had all over the world had the same impression that we need to get the insurance companies to let us use rituximab in that syndrome because it's the only thing that works.
I can't tell you how much I admire this clinical histologic pathologic. We don't get that. You didn't mention genes of a very important patient. We're training a whole generation of physicians now that don't have to have a microscope. My fear is that a generation is not going to have to do it all. This is a biology.
So I So statistically, those are two questions. What was polymyositis and what's the overall frequency of these syndromes? By far, the most frequent of these syndromes is the IMPP syndrome. I was talking before, we're collaborating with the pulmonary people in our place to just sending patients back and forth looking for people who have IMPP. There are two antibodies that are associated with IMPP syndromes with slightly different spectrums of disease. The antisynthetase syndromes virtually all have this pattern of disease. And the other new myopathy that I didn't mention today is the antibodies that are associated with HMG-CoA reductase or HMG-CR antibodies that some people have wrongly called statin myopathies. They're not statin myopathies. Statin is a risk factor. But in any case, those myopathies are also IMPPs. What Andy Engel called polymyositis in 30 years ago is actually the inflammation that's associated with inclusion body myositis. And so it was the pathologic definition of polymyositis was wrong. It defined an untreatable group of diseases and is responsible for a lot of the untreatable inflammatory myopathies, particularly in older patients. And so that's a second very common cause of quote-unquote polymyositis. I think that what you need, in order to really answer your question about what polymyositis is, I need to go back and look through the microscope and see what the pattern of lymphocytes is. If it was endomysial, then it was probably inclusion body myositis. If it was perimysial, then it was probably BCIM.
Last question and a brief one.
Excuse me? Anything wrong with what cells? Satellite cells. So in all of these diseases, the satellite cells proliferate. I think that what happens with satellite cells, depending on exactly what the disease is that if a satellite cell is sitting right next to a muscle fiber, it differentiates into a muscle fiber. But if it's not quite next to a muscle fiber, it goes down to a different pathway and turns into an adipocyte. So the bottom line is there's nothing wrong with satellite cells, but sometimes the proliferation ends up producing other than muscle, and then you get fibrosis or fatty replacement.
Well, thank you so much for being with us. We want to send you home with a Louisville Slugger.
Thank you.
If you had one of these last night and you weren't happy about the debate, you could have destroyed your radio with it. Dr. Alex Pestronk, Medical Background, University of Louisville, October 20th, 2016.
Thank you. Reminding me that the Cardinals didn't do good this year.
Thank you, everyone. Very good. That is true. The Cardinals did not do well. Very nice.
Thank you.
So
Thank
much.
you. Thanks for having me.
This is incredibly complicated. I'm glad you